Hi, and welcome to today's webinar. This is David Ford, the Executive Director of CalHIPSO. I'd like to thank everyone for making the time to be with us here today. It looks like our attendees are still rolling in, but out of respect for everyone's time, we are just going to go ahead and get started. So one thing before we get started, we will be doing a Q&A section at the end of the webinar. However, with the pretty large number of attendees that we're expecting in this webinar, it would be a little unwieldy for us to open the line. So what we're asking everyone to do is use the chat box, which should appear on the right side of your screen, where you can type in questions while the panelists are talking. And at the end of the presentation, time allowing, we will get through as many questions as we can. If you really need an answer and we just don't get to your question, by all means, feel free to email us after today's presentation at info@calhipso.org. And because I know it will be the #1 question, and it is always the #1 question, I would like to let everyone know that this webinar is being recorded. At the end of today's webinar, within about the next 24 hours, we will be posting this webinar on the CalHIPSO YouTube channel, and you will be able to see the slides from today's webinar on the CalHIPSO website. Never fear if you missed it in part of it, or if a colleague missed it today and really wanted to see it, it will be available in those places, I would say usually about 24 to 48 hours after the close of the presentation. So I'm just going to go through a couple things very quickly, because we find on these webinars we get a lot of folks who are not familiar with CalHIPSO, which is great and welcome, and we're happy to see you here. But just a little background, CalHIPSO was founded just about 10 years ago through a confluence of interest with the California Primary Care Association, the California Medical Association, the California Association of Public Hospitals and Health Systems. And CalHIPSO was originally founded and funded to be the regional extension center for almost all of California to help providers navigate the world of electronic health record adoption. And nowadays, since EHR adoption and meaningful use are dwindling as needs among the provider world, CalHIPSO is branching out into a lot of different areas. While we are still doing a little bit of meaningful use, now called promoting interoperability, in the Medicaid, which we call Medi-Cal program, we're also working on things such as encounter data submission, practice transformation support for accountable care organizations, and a few other things. As the needs of our providers have gotten more diverse, we're getting more diverse in our offerings. Over the last 10 years and across all the programs, CalHIPSO has provided technical assistance to, actually that number is a little outdated, but a little over 13,000 clinicians, spanning about 1,400 different provider organizations up and down the state, and we've helped providers earn more than $300 million in federal incentive dollars. So today, we are thrilled to be joined by Gregory Howe, the Senior Program Officer for the Center for Healthcare Strategies. As you see on your screen, Greg Howe works on initiatives focused on populations with complex health and social service needs and the design and implementation of value-based payment models. In this role, Greg works with Medicaid leaders across the country by providing technical assistance to states developing value-based payment models, supporting state efforts to successfully implement and monitor 1115 waiver initiatives, and helping states identify Medicaid financing options for sustainability. Project Echo, he works on Project Echo, a telehealth mentoring model that enhances specialty care in underserved community-based primary care settings. Before joining CHCS, Greg coordinated the development and implementation of healthcare policy in Pennsylvania Governor Ed Rendell's Office of Healthcare Reform. So Greg, thank you so much for being here today. We are going to pass control of the webinar to you and take it away.
Great. Thank you, David, and thanks to the entire CalHIPSO team. I really appreciate the opportunity to be part of this webinar. So for those of you who are, let me see, sorry, just trying to get to the next slide. All right, for some reason I'm not able to advance the slide.
Well, Craig, go ahead and try using the arrows on your keyboard or the space bar on your keyboard and see if that'll advance the slide for you.
Yeah, that doesn't seem to work either.
Okay, give me just 1 second, I'll figure it out.
Okay. There it is. All right, now it's working. So for those of you who are not familiar, I'm sorry?
Thank you, Jason. Take it away, Greg.
Oh, sure. Sorry about that. So for those of you who are not familiar with CHCS, we are a nonprofit policy center dedicated to improving the health of low-income Americans. Our mission is to support innovations in care delivery and improve the health of low-income Americans. As I said, particularly individuals with complex and high-cost needs. To achieve our mission, we work with states, health plans, providers, community-based organizations, and federal policymakers focusing on 3 priorities that are on the screen. And those are integrating services for people with complex needs, advancing delivery system and payment reform, and building Medicaid and cross-sector leadership capacity. I also I wanted to add by way of background, that CHCS, with a grant from Blue Shield of California Foundation, supported the California Department of Healthcare Services in designing the FQHC APM pilot, which was not approved by CMS and ultimately was not implemented in California. And I'll say a couple words about that further along in the presentation, but just wanted to mention that. So I'd like to cover a number of things during the presentation today. Some of you may have listened in on our national webinar that we did back in August on this topic, and some of the content was also covered there, but not everything I'm going to be talking about today was covered there, so there's some other things as well. So today I'll be highlighting findings from a report that CHCS released this past spring, which is on the screen. I'll be identifying capabilities needed by FQHCs to implement value-based payment. I'll be describing FQHC VBP approaches, and I'll be providing examples of promising FQHC payment models. So this past April, as I mentioned, we released a report called Accelerating VBP in California's FQHCs, Options for Medicaid Health Plans, which is available on our website. The report was funded by the California Healthcare Foundation and Blue Shield of California Foundation. It focuses on how MCOs and FQHCs can form innovative and mutually beneficial VBP arrangements, and it explores examples from across the country and in California. So the foundations that supported the report wanted to build on the work that was done by the various stakeholders around the APM pilot that I just mentioned, and look at ways that health plans and FQHCs could engage in partnerships that did not require state or federal approval. So we conducted interviews with 28 stakeholders in California and around the country to inform the report. Those stakeholders included leaders from FQHCs, managed care plans, ACOs, state health plan and primary care associations, national associations, and state officials. So we asked those stakeholders about existing and proposed health plan and FQHC VBP arrangements, as well as state-level APMs, including topics around program design, methodologies, and lessons from those efforts. So when we refer to value-based payment, we're referring to a broad set of performance-based payment strategies that link financial incentives to providers' performance on a set of defined measures of quality and or cost or resource use. So the goals of VBP are to improve quality of care and health outcomes, to lower costs, and improve the patient's experience with the healthcare system. So many FQHCs are participating in VBP programs, as you know, particularly health plan pay-for-performance programs. In our report, what we tried to do was move beyond the P4P initiatives and focus on the ability of plans and providers to impact care across the healthcare spectrum by moving from incentive programs that focus on an FQHC's own quality to new payment models that impact the quality and cost of care patients receive beyond the FQHC walls. So this approach to VBP aligns with the commercial market, and for those entities who implement VBP, it can be a competitive advantage. In this space, there are opportunities for partnerships between health plans and FQHCs, and as I mentioned earlier, these partnerships don't require state or federal approval. So what are the benefits of value-based payment? So specifically for managed care organizations, there is an opportunity for better quality and reduced costs, a greater provider stake in cost management, and finally, VBP creates a greater alignment between provider level and plan level functions. For FQHCs with value-based payment, there's an opportunity for greater flexibility on the types of services provided and the ability to provide services beyond the traditional scope. There's also a greater ability to exercise control on care management through access to better data, and there are opportunities to earn bonuses and incentives to support those activities. As I mentioned before, it can also be a competitive advantage among other primary care providers. It aligns with the commercial market that's already embracing greater accountability, and there's a few other reasons, such as access to resources to enhance care coordination, address social determinants of health, better data for care coordination, predictive modeling, and understanding a health center's own costs. It moves away from encounter-based visits. It allows FQHCs to offer services outside the traditional scope, allows team-based care. It can increase provider retention, and it also means greater revenue predictability. So I'd like to get into some of the capabilities that FQHCs need in order to be successful in these VBP arrangements. In the report that I mentioned earlier, we addressed challenges for implementing value-based payment in FQHCs. We don't really lay out the capabilities in that report, but for this presentation, I want to pull out some of those from our work in this area because I think they're important to frame this larger conversation or this larger discussion. Also, they're not in any priority order or sequencing, but putting them in broader buckets, those capabilities include being able to implement care models to manage complex patients, using data to support care delivery, improve quality, and reduce total cost of care, coordinating effectively with external providers and community-based organizations, and building internal and external supports for these efforts. And I'm going to go into detail on each of these, but all of this together, obviously, it involves tracking patients' outcomes and costs. It requires potentially significant startup costs, and it means changing business as usual. So let's start with the first bucket, which is implementing care models to manage complex patients. So effective care coordination models need to be designed or adapted to meet unique health center needs. They're built around team-based care. They integrate clinical guidelines, both internally and across sites, if there's more than one site. They incorporate changes in the workflow, and they utilize a designated care coordinator on-site, versus a telephonic care coordinator who has clear roles and responsibilities. And of course, developing these capabilities requires leadership, staff resources, and training. The second bucket I want to talk about is using data to support care delivery, improve quality, and reduce total cost of care. And I'm going to break this into two parts. So the first one, this slide, is essential capabilities. And these are primarily for value-based payment efforts like pay-for-performance, where a health center is tracking the care that its patients are getting at the center itself. So at a basic level, there needs to be an EMR to support care coordination and to capture data. There needs to be training and monitoring to ensure accurate coding, the availability of tools to perform basic data analysis, and a defined staff person, not necessarily, that's their only job, but a defined staff person to manage quality reporting and monitoring. So to step it up a level, advanced capabilities, and these are for more advanced initiatives that address total cost of care. And these capabilities include the ability to share data with external entities like specialty providers, the availability of a data warehouse to support data sharing and analytics that would include EHR clinical data, payer claims data, admission, discharge, and transfer data. Capabilities also include IT tools for managing care in real time, such as dashboards and shared care management plans. And also, frontline staff need to know how to use real-time data in delivering care. There needs to be clear processes in place for that. Also, capabilities include analytics to track attributed patients and assess total cost of care outside of the health center's walls, which I mentioned before, and potentially predictive modeling. The next bucket of capabilities addresses coordination with external entities, external providers, and also community-based organizations. So for these capabilities, health centers need to be able to develop and maintain relationships with existing and new partners, including hospitals and other provider groups. So for example, specialists, behavioral health specialists. They need to be able to track and understand where care is delivered outside of its walls, which speaks to the relationships, and to be able to create shared care management plans, which I mentioned earlier around sort of data sharing and care coordination. Health centers also need to be able to manage transitions of care. There needs to be processes in place to do this. So, for example, what's the process when a health center gets a report that one of its patients has been in the emergency department or has been discharged from the hospital? How does that real-time data, how does this get acted on? Which is a really key consideration here. So the last capability that I have listed here is working with community-based organizations to identify and address social determinants of health. And also this means building that into the workflow. So the last bucket of capabilities is building internal and external support. Health center leaders need to understand value-based payment, which means that they can articulate the vision for that. They can address contracting and implementation challenges. It also means that the leadership understands the center's value proposition. What is the value that the center brings to a health plan? And this is important in terms of negotiations and working through those agreements. Leaders need to actively support VBP efforts internally and in the community. Another key capability is around building collegiality among staff. This was raised by one of the FQHC ACOs that I'm going to describe in a minute as really one of the most important ingredients here. Also, leaders need to clearly communicate changes to staff. Sometimes VBP arrangements are worked out between health plan leaders and health center leaders, and they don't get shared to the staff who are doing the work. There needs to be clear roles and processes that are developed and defined. It's really important for health centers to engage health plans to identify shared goals, which involves coordinating resources, addressing data challenges, patient attribution, et cetera. It's also really important to build those, those relationships, around what's important. Where are there win-wins for both entities? It also means engaging patients and other providers and other community leaders externally. So we talked about why value-based payment is important, and we also talked about the capabilities of health centers and what they need to be able to do in order to be successful with VBP. So now let's look at some value-based payment approaches. So in the report, we look at payment models that can help move along the continuum toward greater FQHC integration and accountability. And I'm not going to get into the details of those models. And these are models that are not necessarily just related to FQHCs, but more generally around value-based payment. But I wanted to do some quick level setting here by briefly mentioning 4 of the most common VBP approaches, which are on the screen, and I'll jump into a little bit more detail here in a minute. So starting with pay for performance, and many of you are familiar with P4P, it ties provider payment directly to specific indicators of quality or efficiency. A pay for performance program typically includes rewards. Providers receive a bonus payment for measurable performance and quality, patient satisfaction, resource use, or cost. Also, pay for performance programs include penalties where payment is withheld or clawed back based on performance. Actually, for some reason, I'm getting a little bit of feedback. I don't know why that is, but sorry I mentioned that. So next payment model is bundled payments, and under this model, providers receive an all-inclusive payment for a specific scope of services to treat an episode of care, which has a defined start and end point. So these bundles can be for acute or chronic events. This model incentivizes coordination across physicians, hospitals, et cetera, to provide care at or below the payment level. So there, typically could be for a procedure such as a knee or hip replacement, or a condition such as diabetes. They can even be for a setting such as a hospital or hospital stay. So they're defined that way. And also in this model, payment is contingent on quality performance, and the payment can be made either retrospectively or prospectively. The third model that I want to talk about, spend a little bit of time on, because many of these ACO models, include this payment model, which is shared savings or risk. In this model, providers that succeed in keeping costs below a total cost of care benchmark keep a percentage of the savings. This model incentivizes activities like coordination and effective care management across all services that serve to lower the total cost of care. So payment is received retrospectively and is contingent upon quality performance. This model is utilized primarily in ACOs, but can also be found in other initiatives like patient-centered medical homes and health homes. And this slide, the next slide here, shows, the graph on this slide shows how shared savings models work. And some of you are very familiar with this model, but I thought it'd be helpful just to do a quick kind of overview of how it works. So the black line in the middle represents projected expenditures. If the expenditures are, for example, 10% below projection, which would be the green line, then the provider and payer share the savings. If the expenditures are 10% above the projection, which is the orange line, then there's 2 possibilities. So in an arrangement with a downside risk, then the provider and payer share in the losses. In an upside-only model, then the payer shoulders the full amount of the losses while the provider is not responsible for any of it. And of course, payments are contingent on meeting quality targets. So the last model that I wanted to briefly touch on is global or capitated payments. In this model, providers receive an upfront per member per month payment to cover a wide range of services. By receiving a lump sum payment that's tied to quality, there are incentives to look across the full spectrum of care and deliver care that is better coordinated across primary care providers, specialists, and hospitals. So if expenditures fall below the budget, the provider gets to keep those savings in full and reinvest them. This gives providers a great deal of latitude. This model typically applies to larger provider organizations that have the ability to manage the risk fully, since they are on the hook for all care. It could also be part of like a statewide model. In Oregon, for example, coordinated care organizations receive a global budget, and that's the model that they work under there. So for FQHC specifically, one of the obvious challenges for these VBP models is dealing with the rules around the prospective payment system, or PPS. In Medicaid, as the FQHC folks know, federal law requires that FQHCs be reimbursed for all reasonable costs associated with the services they provide through PPS or an alternative payment methodology based on health centers' historical costs of providing comprehensive care to Medicaid patients. So each FQHC has its own PPS or APM rate. If a state chooses to reimburse health centers via an APM, two statutory requirements must be met. Each health center must agree to the APM. And secondly, any payment would need to be less than what a health center would have received via the PPS rate. So the latter provision has historically limited the types of VBP arrangements that states and plans can enter into with FQHCs. So those with downside risk, as the direct payments to FQHCs cannot decrease under VBP arrangements. So what are the options then for health plan and FQHC contracts? Well, FQHCs can contract with MCOs through an upside-only VBP arrangement without concern for PPS restrictions, and that means that they can be designed to meet federal PPS equivalency requirements by not putting the PPS at risk. And these can be through all of the models I described above: pay for performance, bundle payments, shared savings, or risk-based capitation. There are, however, three ways that FQHCs can participate in VBP arrangements with downside risk that fit within that statute. And this can happen in VBP programs involving services that are not covered under PPS rates. It could also happen where MCOs could pay FQHCs rates above PPS and put that portion at risk. And that happens in some examples I'm going to talk about in a minute. FQHCs could also join in VBP arrangements with organizations that are capable of taking on risk. And I'll also talk about that in a minute too. So let's talk about those real life examples now where that's happening. I'm not going to spend a lot of time on this slide because I know that our focus today isn't necessarily state-led initiatives, but I wanted to give you a quick overview because I think there's some useful learnings here from these models that could apply to local efforts, and also because there was a lot of work done in California to design one of these models, which I mentioned earlier, which ultimately wasn't implemented. So there are basically three versions of state-led VBP models for FQHCs. The first one is the capitated APMs. The next one is quality rate adjustments, and then on the next slide I'll get to the Medicaid ACO upside-only shared savings programs. But the first one, the capitated APMs, there are right now only two states that do that, which are Oregon and Washington. Colorado is working on one and waiting for approval by CMS. It's currently under review. The California APM pilot that I mentioned earlier is similar to those models, except that the California model would have established a threshold for reconciliation that deviated from the PPS equivalency provisions, which then meant that the health center payments were at risk. So actually, I'm just going to skip the next ones because in the interest of time to make sure we can get to the other models. If you're interested in reading more about the state-led APMs that are in practice in Oregon and Washington and Arizona, feel free to look at our report where we talk about it in a lot more detail there. So let's talk a little bit about FQHC-led Medicaid ACOs. And these are two ACOs that are part of state-directed ACO, Medicaid ACO programs. So the first one is in Minnesota. It's the FQHC Urban Health Network, also known as FUN. It's an FQHC-only safety net Medicaid ACO. It's part of the state's Integrated Health Partnership ACO program, which launched in 2013. It includes 10 FQHCs that include 40 sites. FUN leveraged $1.5 million in state and federal grants to develop an IT infrastructure to support data analytics and to share real-time information. That was a huge upfront investment that they did because they saw that as being critical to the success of their program. So so in Minnesota there are a number of ACOs. I don't remember how many, I think 30 some maybe by now. And FUN is one of those ACOs, which is made up only of FQHCs. So in this model, there are shared savings payouts based on total cost of care and meeting quality targets. The FUN organization distributes those savings among the FQHCs, and in this model, those savings are upside only. The PPS is not put at risk at all. So the health centers continue to receive their PPS payments, and then the shared savings, if there are any, and there have been, get distributed beyond that PPS. I just wanted to kind of make that distinction. So the second ACO that I wanted to highlight is in Massachusetts. It's the Community Care Cooperative, which formed as an ACO in the state ACO program. There are a number of tracks that ACOs can choose to participate in through the state. C3, which is the abbreviation for Community Care Cooperative, they decided to participate in one of those tracks. They're the parent organization that includes 19 FQHCs. They launched in 2018. They're taking an incremental approach, which means that for the first year, they're working with the FQHCs to develop capacity, to do baseline performance or paper reporting processes. Year 2 includes incentives for meeting quality targets, and year 3 is shared savings based on total cost of care, which is similar to what's happening in Minnesota. But a couple of things I want to point out here. One is that the ACO supports the health centers by centralizing some of the business functions. They're spending a lot of time on building the data infrastructure, standardizing clinical guidelines, and care coordination activities. They're also investing in that IT infrastructure and data sharing capabilities. They're also building capacity for financial management and helping the centers deliver population-based care. They're working through issues related to patient attribution, et cetera. A lot of great work is going on there. Again, they just launched, and they've seen, as I understand it, they've seen some pretty positive results already. So I know I want to be mindful of time here. I just want to share a couple more examples, regional examples of VBP arrangements with FQHCs. The first one is the Accountable Healthcare Alliance of Rural Oahu, which is in Hawaii. This is a collection of 4 FQHCs that are participating in a joint accountable care arrangement. Howe has VBP contracts with 4 health plans. So it's the single point of contact for the Medicaid health plans. There's 4 of them, 4 health plans that are part of that. The participating health centers receive an upfront PMPM payment, some of which goes to the parent organization for things like building capacity, clinical integration, developing dashboards, et cetera. So the FQHCs are required to participate in quality initiatives. They're also required to offer expanded office hours. One of the health centers actually decided to be open 24 hours in a way to impact the ED utilization rate. They're also required to address social determinants of health and report on quality and performance measures. So they also have a shared savings arrangement. What they would tell you is that the part that's really important is the upfront incentives, the upfront PMPM, which allows them to make investments. But the shared savings, of course, is also important on the back end as well. So they see this arrangement, Howe sees this arrangement as mutually beneficial to both the FQHCs and the MCOs. They have identified 3 key elements that make this work, which is trust, correctly aligned incentives, and the transparent exchange of data. Moving now to Chicago, the Medical Home Network Accountable Care Organization in Chicago is made up of 9 FQHCs, 3 hospital systems, as well as the hospital's physician practices. Medicaid patients are attributed to the ACO if they choose one of the participating PCPs as their medical home. I think an important distinction here is that MHN partners with County Care, which is the Medicaid Health Plan run by the Cook County Health and Hospitals system. The MCO provides an upfront payment to MHN, and there's also a quarterly shared savings payment if that is earned. MHN distributes the payment to its partner organizations based on performance. Another critical piece here, and you're probably noticing a theme, is that is related to data, IT infrastructure, and data sharing. For MHN, they used the MCO funds to create MHN Connect, which is a data sharing portal used by ACO providers that provides real-time actionable data. It doesn't replace the HERs, but it is the main vehicle of communication between partners and for monitoring measures that determine the shared savings. And MHN Connect also connects with other non-ACO hospitals, which I think is an important distinction. So finally, the last example I want to share with you all is the Rocky Mountain Health Plans and Mountain Family Health Centers partnership. For those of you who were able to listen in on the webinar in August that we did, which is, by the way, the recording's on our website, Patrick Gordon, who's the CEO of Rocky Mountain Health Plans, and Art Fernandez, who's the Chief Operating Officer of Mountain Family Health Centers, both did a presentation with a whole lot more detail about their partnership, which is really exciting. And I would invite all of you to listen to that presentation and get all those details there. But as a quick overview, I'll just kind of share some of the highlights, which is Mountain Family has 4 sites that participate in the arrangement as part of Colorado's Prime program. They're in a contractual relationship with Rocky. In that relationship, the health center receives a capitation payment, which provides cash flow, revenue certainty, and predictability, and has really allowed the health center to add staff across the spectrum of care to provide more services and better care coordination. They also receive incentive payments, which they also use for capital investments. So an important part of this partnership is that Rocky invests in the arrangement by providing tools for data integration, care management, financial management. They also share clinical and cost data on attributed patients directly from the health plan. There are a number of community engagement strategies that they use to make sure that they're coordinated with hospitals, community health, mental health centers, and all of that has led to better overall outcomes for patients, and they have a lot of data to back that up. So just to wrap up, I just want to mention a couple of things, themes that sort of flow throughout our work in this area, which is there's an alignment of mission and goals between the partners in these arrangements. There's also a high level of trust and transparency among partners, along with good communication. There's a defined governance structure between equal partners. There are strong delivery systems and strong data infrastructure, which is critical to the success of these initiatives. Super important is knowing who the other entities are in the system and building relationships with them. So beyond the health center walls, what are the other providers that are caring for patients? The final thing I'll just note is to be successful, there needs to be a high level of buy-in from everyone within the organization. So I probably ran over time, but I'll stop there, and I look forward to answering any questions at the end.
All right. Thank you, Greg. And now, so with all of what Greg just said there as backdrop, let's talk a little bit about what CalHIPSO is working on. And to do that, we're going to bring in another one of our partners. And so we're going to pass control of the webinar over to Matt Kendall, the Executive Vice President of Aledade. As many of you know, earlier this year, CalHIPSO launched a major partnership with Aledade to do work in value-based care right here in California. Matt, it looks like your line is still muted, so if you can take yourself off mute, and then we'll pass the control of the webinar over to you.
Hey.
There we go.
Can you hear
okay.
Me? Thank you.
Now we got you.
Well, this is so great. And again, I really appreciate the opportunity to talk to you guys today. I think Greg's presentation was excellent because one of the things that Aledade has been doing recently with CalHIPSO is thinking about ways in which we can engage partners throughout California, but specifically FQHCs in value-based care. So I thought it might be helpful to give you guys a little context about myself before I talk really briefly about what we've been up to. My name is Matt Kendall, and I'm the Executive Vice President for Provider Networks at Aledade. But before that, I started my career running a federally qualified health center in San Jose, California. That's the little health center there. And then after that work, I went and worked for New York City for the Primary Care Information Project, where we worked with all the FQHCs in New York City, looking at ways to help them adopt EHRs. And after that, I went and worked on the federal level. I was the director of the Office of Provider Adoption Support, where I led the effort to help regional extension centers like CalHIPSO engage over 143,000 primary care providers across the country and get them to use EHRs in a meaningful way. And we did this not to torture folks, but we did it because we really were anticipating that there were new value-based programs coming forward. And when I discovered that folks really weren't engaging folks like FQHCs and independent providers in those new models, Farzad and I launched Aledade to support that. So, our network right now is, we're in 25 states. We just expanded to California. We primarily focus on the Medicare Shared Savings Program, or MSSP, which is a type of shared savings ACO, like Greg described. It starts with the Medicare population. But what we try to do is really engage our practices to provide comprehensive support and workflows that can work with any different payer. And our goal is to get as many patients in a practices panel in value-based care models as possible. So a lot of FQHCs start with us, even though they have a very small Medicare panel, but it gives them an opportunity to learn how to do this, and then we expand it to other payers across the board. And come January 1, we'll have 40 ACOs across the country. We'll have probably about 40 other value-based care arrangements, and we will be supporting a lot of different work. And the way that Aledade operates is we really focus on providing comprehensive support to our practices. We know that this is hard, and I think Greg talked a lot about the challenges that people have to do this, and they are daunting. But a lot of what we do is try to make it as easy for our partners. And that starts with policy and understanding the policies, making sure you can understand the rules. I mean, great job of talking about some of the nuances with PPS and things along those lines. We also want to work with all payers. So we align contracts to make it easy so to have similar reporting requirements. We provide a comprehensive analytic population health app and analytic framework that mines the data of our existing EHRs and practice management systems to get actionable insights. And I think this is important because you've got to have clear goals when you're in these programs, but also have ways in which you can get the right information in the right way to practices as you go forward. We also provide a ton of education, training, and local support, and this is where our partnership with CalHIPSO comes in. They're working with us to go into practices to help do this work because we know this isn't easy and you need to think about how to do this. And then we also spend a lot of time thinking about how to optimize the EHRs that are in a practice already, but also how to link them to things like state health information exchanges. And all the time we're doing this, we're thinking about ways in which we can improve care coordination among our practices, because that's the way you increase quality and decrease costs. So we've been pretty successful. We are working with over 90 different EHRs. I sometimes joke that this is sort of the results of running the Regional Extension Center program, is now I have to deal with all the different vendors that program sort of gave rise to. But that's good because we were able to get data out of those systems to make it actionable. We then take that data and we blend it with claims data that we get from payers. So Medicare, as part of the MSSP program, provides us claims data, but we also negotiate it any other contract that we get. Because we really want to give providers access to information about what's happening outside their practice. And claims data, when vetted and analyzed correctly, can be very important and impactful. We then use that data again to come up with targeted interventions for our practices that are things that they can do. So we focus a lot on things like annual wellness visits, transition of care management, chronic care management. Some of these federal programs that also have state equivalents, and really helping people understand the impact of things like risk suggestion, and looking at things like specialist utilization. And making sure people get preventative services. All those things are important in these programs. And what we found is that we've been really able to drive lots and lots of success, not only in getting checks into the hands of our practices, which is one of the best things that we do. And today I was writing a couple checks for this year's shared savings to some of our FQHCs, and there were 6 figures. And this is money that's well needed in these practices. But we also do things like it's important to keep in mind that the work we're doing is also keeping people out of the hospital. It's helping quality of life. It's taking waste out of the system, which is helpful across the board. And from Allied, we actually have a lot of experience with community health centers and FQHCs. We've got some ACOs, such as our family health ACO, is getting savings year over year. But we have other ACOs in Kansas that just got savings for the first time this year. And as a matter of fact, we will have 6 ACOs that are nothing but FQHCs starting next year, because I think there's a lot of interest in we're beginning to branch out into states like Arkansas, Mississippi, Louisiana, West Virginia. All these places we're seeing that there's a huge movement. And we've been able to not only get the shared savings, but help folks figure out ways of getting more fee-for-service. So even with the prospective payment system, there's incentives that Medicare provides for annual wellness visits that can actually increase FQHC revenue right away. And we've been able to generate lots of dollars for our practices by helping them get those patients in, get them the services that are necessary. And then finally, giving them an opportunity to be seen correctly. Risk score is a bad tool, but it's the only tool that CMS has to judge how sick a patient population is. And unfortunately, because of PPS historically, our FQHCs aren't very good at that. So it turns out that CMS thinks their patients are a lot healthier than they actually are. And by helping people to accurately reflect the risk status of their patients, it really lets them be compared on a level playing field. And that's where they thrive. So on the whole, I think there's a lot of different ways in which we've been working with folks. We're excited to do it. And as Greg sort of alluded to, there are lots of different ways to approach this, but we feel that the shared savings approach is the quickest way when people are giving comprehensive support that they can be successful. So David, I'm not sure how you want to run the Q&A, but I'll hand it back to you.
Okay, great. Well, thank you, Matt, and thank you to both of our presenters today. And as we get into Q&A, we do have a few questions in the question box, but if there's any more you would like to add, we have about, I think, 10 minutes before we wrap. But as I say, there are just a few that are left that came up during the presentation, so we'll go through a couple of those quickly. And one of those, I knew this was coming. I said it way back at the beginning of the webinar, and it was still the first question is, are we providing the PowerPoint to the participants? So go through that one again. Yes, this will be available at CalHIPSO. We do a couple things. This webinar is being recorded. It will be posted to the CalHIPSO channel on YouTube. It will also be linked to our website, and the slides will be available on our website usually about 24 hours after the webinar. So don't look for it later today, but maybe about midday tomorrow, hopefully it will be up. So this will be available if you want to look back over things, or if you have colleagues who couldn't make it. We do make those available after every webinar. Now, on a more policy level, we have a question. Can you talk about how these value-based payments have increased HEDIS scores above the 50th percentile? And in case anyone's not aware, Medi-Cal is changing the rules in Medi-Cal managed care and making 50th percentile nationally the minimum performance level. So, Greg, maybe do you want to take a stab at that one?
Yeah, I can. I don't know that I have a lot to offer here, but and maybe Matt can jump in as it relates to the work that he's done. I don't have any specific data around how these arrangements are impacting HEDIS scores. I think that's a good question. I think generally, just to take it up to a very broad level around value-based payment, I know that there's questions about, and there's been studies, there's been a lot of research on the MSSP models in Medicare in terms of the outcomes and effectiveness there. But I do know in California, and we convened a group of health plans and FQHCs back in May to talk about this very topic and to talk about the report. And there were there was a lot of talk about changes in the quality program for the MCPs in California, and a discussion around how could VBP models move the needle on the HEDIS scores. And I think there was some optimism that this is a way to do it, but I don't have any specifics around around that particularly. I don't know if Matt has anything to add.
Well, yeah, HEDIS quality measures is an important part of any value-based contract because it's sort of fundamental. And actually, it's interesting. It's sort of a byproduct of what we do. If you're providing high-quality care, it generally tends to keep your patients healthier, which decreases total cost of care. So it's something that we actively support. And I'm proud to say that all of our ACOs that we support, both our health center ACOs and those who aren't, showed exceptional scores on the subset of measures that are related to the MSSP program. So I think it's definitely doable. I know that the concern about these measures, but I think one of the thing that is most imperative is making sure that any measures you have are risk adjusted. And if they are risk adjusted, you've got to understand what that means and how to do it so you can get accurate representation. We've seen our health centers undervalued because they weren't properly risk coded.
Great. Well, thank you both for that perspective on that question. The only other things in the question box right now are a couple of notes about the background noise and some of the feedback we've had during this webinar. That was user error on behalf of CalHIPSO, so I apologize for that. But we have just a few more minutes, so I'll just ask one more time if there are questions. Please enter them in the question box now. And if we don't, maybe we will wrap a few minutes early and give everyone a few moments of your day back. With that, not seeing anything, I guess we'll wrap it up. Definitely want to thank our presenters, Greg Howe and Matt Kendall, and thank all of you for taking an hour out of your busy day to be with us here on the CalHIPSO monthly webinar. And if you have any follow-up questions that come up later, the email address is at the bottom of the screen, info@calhipso.org. We're always here, so feel free to email us at any time. And be looking in your email inbox for announcements of future CalHIPSO monthly webinars. Thank you, everyone, and we'll be signing off.